RFP. And next slide, please. So just as a little bit of a level setting and overview, the RFP, which is what we're all here to talk about, was announced in late May. The Department of Health and Human Services from the state of Michigan provided about a one-page, maybe 1 1/3 page kind of overview that was all the guidance that we had for a good 2 months until August 4th when the RFP was actually released. So now that the RFP has been released and we are aware of at least some of the parameters regarding the state's intention to open the public behavioral health system to potential management by private organizations, we know that who is eligible, which includes currently with the new amendment, public organizations, private nonprofit organizations, and public universities, and then also the 3 new regions, which are shown on the map. So Oakland County would be merged with Wayne and Macomb County, which Ms. Lazenby just discussed. So we also know that the RFP is due at the end of September, and the changes would be effective October 1st, 2026. So we're looking at a little over a year. Next slide. And so with the limited amount of information that we have received, what we know is that the RFP will not solve current problems that we have with incorrect Medicaid redeterminations from the state, which has seriously impacted service coverage for a number of individuals in the network, a chronically underfunded system, the federal Medicaid cuts, which will be effective beginning, as far as we understand, beginning October of 2027 to the tune of cuts potentially $2 to $4 billion for Michigan alone annually, ongoing workforce shortages, and high administrative rates that we see with private entities. Next slide. But still, what we don't know, and we're gathering everybody here today to discuss what the impacts could potentially be, but we still don't really know what the real plan is for the system and what the department really has in mind. So what opening the public system to private bidders will mean at the end of the day, and we don't know exactly what kind of program changes will be made and whose services could be impacted, but we do know that over the past several decades that families and individuals have said no to privatization over and over again. So next slide. So in terms of advocacy, we're so excited that everybody is here today. This is part of our effort to bring everybody together, figure out what makes sense and what we can do. We've been working with our partners at the county level, and we have a bunch of support from the Board of Commissioners. They passed a resolution for us and provided a letter with the county executive, David Coulter. We have support from our sheriff, from the Association of Chiefs of Police, and then also the 52nd District Court. So they know what privatization and merging services with 3 counties could mean for, in particular, our justice programs, recovery programs, and court programs. So, we have a lot of support that way. So with that, I will hand it over to our first speaker, or are we doing...
I'll do it from here, Francis.
Okay, so Ms. Lazenby will do some introductions, and then we'll move on. Thank you.
So we don't waste any time going back and forth. I'm going to pass it over to Mr. Kevin Fischer, who I believe he has a member of his team who's going to speak to some of the advocacy. But Kevin Fischer is the Executive Director and CEO for NAMI Michigan, the National Alliance on Mental Illness, which is the nation's largest grassroots mental health organization dedicated to building better lives for millions of Americans affected by mental illness. So Kevin was a former businessman. I believe he still is. He joined NAMI as a volunteer in 2011, after his oldest son, Dominique, was diagnosed with mental illness in 2007, and he lost his life to suicide in 2010. So with that, Kevin has been such a strong advocate, a mental health and suicide prevention advocate. He's appointed to several different foundations and committees across the state, including the board of directors, behavioral health organizations, including the Governor Whitmer's Suicide Prevention Commission, MDHHS, Mental Health Diversion Council, and Behavioral Health Advisory, among many others. It'll take us all afternoon to read. But I just want to say thank you so much for Kevin for sharing not just his professionalism and his ability to get people in a room to listen, but just his personal story. It takes a lot of strength to share your personal story. And I think when people hear that, they listen and they know the critical importance of community mental health. So thank you so much for being here.
Thank you, Dana. It's my pleasure to be here. We're going to change the agenda just a little bit. As Dana mentioned, the NAMI National Chief Advocacy Officer, Hannah Wesolowski, is going to be joining us virtually, and I want to give Hannah opportunity to present her information and make sure that I'm not being redundant, but I also want to thank Hannah for being here with us today. She is a phenomenal resource as it relates to keeping me and most of the nation up to date in what's going on in Washington, D.C., and how we can best protect the rights and resources for the people we serve. So do we have Hannah?
Can you hear me?
Yes.
Okay, great. So hi everyone, it's really wonderful to be with you and appreciate the invitation. As Kevin said, I'm with NAMI's national office, so I'm in the Washington DC area and have been really following what's been happening, and we've been heavily engaged, particularly around some of the Medicaid cuts, and that's what I wanted to focus on today so that you have context around the federal landscape and what it's going to mean for Michigan from the One Big Beautiful Bill Act, as it's called, and just share a little bit of info of what we're seeing, timelines, what we anticipate, so you can build that into your conversation as you think about next steps of this proposed plan. So thank you so much. So just some high-level summaries to give you an idea. There's roughly $1 trillion in cuts to Medicaid over the next 10 years as the result of the HR 1, One Big Beautiful Bill Act, also called the Budget Reconciliation Bill. Has a lot of different names and reference points. This bill was signed into law on July 4th after a pretty engaged advocacy battle. I will say at the beginning of the year, it was not clear if the overall infrastructure of Medicaid would be kept intact. There were discussions about ending Medicaid expansion. There were discussions around block grants or per capita caps on Medicaid, which would fundamentally change the structure of Medicaid. The overall structure remains intact, although a huge amount of money is coming out of the system as a result of this bill, and I'll talk about from where. The Congressional Budget Office estimates that 10 to 15 million people nationwide will become uninsured as a result of this bill. 10 million from what is in this bill, most of that from Medicaid, although a bit from changes with the Affordable Care Act, but an additional 5 million people because of there is not an extension of advanced premium tax credits that help people afford insurance on the healthcare marketplace. So the impact of not including extension of those tax credits means that an additional 5 million people are projected to lose coverage. And not especially as relevant to this conversation, but I think, again, important in the overall context, roughly $186 billion in cuts and work requirements to the Supplemental Nutrition Assistance Program, or SNAP program, also known as food stamps, something that's going to greatly impact our community. So where do these cuts come from? So there are a few, and they have different implementation dates, so it's a little confusing to keep track of. And a lot of the information is still coming out because while there was definitely policies in the bill, so much of how this is going to be implemented has to first be defined by the federal government and the regulatory process, and then the state has to determine how it will implement those requirements. So a few things that are worth noting. The bill requires states to more frequently determine if people are eligible for Medicaid. So instead of the current once a year, it'll be every 6 months. We know that process often results in people falling off Medicaid rolls for a variety of reasons, not being able to access the paperwork, get notice, they move, the system loses track of them, so many reasons. This will become effective January 2027. There's also cost sharing for Medicaid for the first time ever. States are required to impose cost sharing up to $35 per service, up to 5% of the family's total income for anyone who is covered by Medicaid expansion. So that's anyone over 100% of the federal poverty level, which is about $15,000 for an individual. I will note mental health and substance use disorders were exempted from that, but as we know, many in our community have comorbidities and co-occurring health conditions, and those other conditions are not exempted, so it may deter people from getting care for those other healthcare conditions. Something that's always been really wonderful about Medicaid is retroactive coverage. If somebody gets healthcare services and is deemed within a 90-day period that they are eligible for Medicaid, those services up to 90 days before were eligible for coverage. This shortens that retroactive coverage period. So anyone covered by Medicaid expansion, it's retroactive for 1 month, and for anyone on traditional Medicaid, it's 2 months. So again, these cumulative effects that have an impact on people's ability to afford care, access care, and stay on Medicaid. Now, I'm talking largely about mental health because that is my point of view, but I will note that all of these Medicaid changes apply to substance use, apply to individuals with intellectual and developmental disabilities. There is not an exemption for in the cost sharing for services outside of mental health, substance use, and I think like preventative care. So there will be cost sharing for other services that individuals might seek. If we go to the next slide, please. So you can see this is from the Kaiser Family Foundation, where all of the Medicaid cuts are occurring. And the biggest impact by far is work requirements. This is all going to come from a phased implementation. As you could see from the previous slide, implementation's happening at different times. But there's a number of different changes that are going to cut funds and resources to states over this 10-year period, resulting in that $1 trillion. So I share this just as context to know work requirements is a big part of that, and I'm going to talk about that in one moment. But some of these other things that I've mentioned and other provisions certainly add to that larger pie of cutting $1 trillion out of the system. And so on the next slide, this is where we get into work requirements called community engagement in the bill. This requires states to establish community engagement requirements. Ultimately, it's about 80 hours of work a month that can be work, education, volunteering, and it does have some built-in exemptions. This applies to individuals who are adults between 19 and 64, generally referred to as able-bodied adults. So those are adults that are generally covered by Medicaid expansion. There are exemptions, for example, for having a substance use disorder, for having a disabling mental disorder, for anyone with physical, intellectual, or developmental disabilities, or somebody with serious or complex medical conditions. So that sounds great. There's exemptions. None of these exemptions are defined in the legislation. That's where things get really tricky. How will these exemptions be determined? How will the state track those exemptions? You don't just wave a magic wand and somebody who has an intellectual or developmental disability or a mental health condition is exempt. And that's really the big concern here, that people should be exempt, and we'll find the process to go through and get the exemption very difficult. Or if they are not exempt, they may be working, and the process to prove that they are working is very complex and difficult. So just to give you an idea of the implementation timeline for this, on the next slide, I pulled this timeline Well, it lets you know we don't expect details on how this is going to be implemented from the federal government until next June, but it goes into effect January 1st, 2027. So that means Michigan's going to have a very short period of time to figure out, once we have definitions of what they consider a disabling mental disorder, or what they just consider a physical, intellectual, or developmental disability, how that's defined by the federal government. The state has a very short period of time to figure out how they're going to implement it. Now, some states may be granted a good faith extension into 2028, but CMS, the Centers for Medicaid and Medicare Services, has indicated that they really hope that they don't have to issue those extensions for states to implement these work requirements. Bottom line, this is going to result in a lot of people losing care, not because they're not eligible for care, but because they can't prove that they're working, or they can't prove that they're exempt, or they find the system too difficult to navigate to do those two things. Next slide, please. So just some kind of overall estimates. $200 million was provided in the bill for all states, so a $200 million pot for state implementation costs. I wasn't able to pull Michigan's costs. I'm sure there are folks in the room who know that, but just to see what other states alone have estimated it will cost them to implement some of these provisions, that $200 million isn't going to go very far. So that's additional expense on the state that they will have to figure out. And, you know, the concern from many of us in the healthcare community is, what is that going to mean? Are states going to unwind some of their Medicaid expansion because they don't have enough resources to implement this? We certainly hope that's not the case. And just one other note that I would share, because it was a big topic of conversation with the bill. The bill also included a $50 billion fund for rural health transformation. That's going to be money that is opened up to states to apply for, and we've heard that the timeline for that is in early September. So those are additional resources that states will be able to apply for. Part of that fund will be distributed equally. Part of it will be for application. We think that that's going to have really broad eligibility requirements of how it can be used, but we're also waiting on more details for that. And a lot of that was to shore up health systems, shore up hospitals, shore up community health networks to make sure that these Medicaid cuts don't mean doors are closing. So that's something else to have on your radar and be aware of. And just finally, you know, what happens next on the next slide? As I mentioned, the federal government still has to do a lot of rulemaking to determine what happens with this bill. How are all of these provisions defined? What does it find acceptable for the different provisions in meeting federal requirements? You know, here I have, for example, how will someone prove they have a disabling mental health disorder? Do they need to submit paperwork? What conditions qualify? Is it by symptoms or is it by diagnosis? There are so many things that have yet to be determined. Of course, we're advocating that self-attestation, that somebody, you know, can share that they have a mental health condition, or that there are least restrictive requirements to prove that you have these different exempt conditions, to make sure it's not too onerous on the person who has Medicaid to prove that they are eligible. But a lot of this is going to then go to the state to determine how the state's going to implement it. I know that we're a little behind, so I will stop. The next slide has my email address, as well as some of NAMI's Medicaid resources. Feel free to reach out to me with additional questions. I don't know if there's time for questions now, but just wanted to give you context, because obviously the landscape is changing dramatically over the next few years as it relates to Medicaid, and that impacts what's happening in Michigan.
Are there any questions for Hannah before we lose her? All right. We have one.
Okay.
When it's red.
Can you hear me?
Yes.
I heard you say something about substance abuse. In the state of Michigan, substance abuse is called part of a mental health problem. So tell me again about the substance abuse.
Yeah, so the legislation defines specific medical needs where an individual may be exempted from things like work requirements or community engagements. It's specific language. This isn't our language. The language that includes um, uh, the HHS secretary may accept anyone who is medically frail or otherwise has special medical needs, including someone who's blind or disabled, someone who has a substance use disorder, someone with a disabling mental disorder, someone with a physical, intellectual, or developmental disability, or someone with a serious or complex medical condition. Certainly, different states have different definitions, and many in our community believe that substance use conditions are part of the overall mental health conditions, but this is how it's defined in the legislation in terms of exemptions. It's called out specifically and separately.
Thank you very much.
Thank you.
Any other questions for Hannah?
I had one question. The question I had was about the cost sharing. I put it in the chat, but people like myself that are IDD, how does that work? Because like a lot of us are already on low income and we're already on disability. So how can we pay any more into it because our personal cost is so high with housing and everything else? Can you share on that?
Yeah, no, that's exactly the concern with so many of us in the community. While we were happy that mental health and substance use treatment was exempted, we know that there's a wide range of individuals who have various conditions. So being able to afford those co-payments essentially is a fundamental change in Medicaid, and is very contrary to the goals of Medicaid because, you know, people may not seek care because they can't afford it. I will say it's up to $35 per service. The state can make some determinations of what they will charge, and I think there's a lot of advocacy opportunity to make sure that the state is making that charge as minimal as possible to ensure that individuals can still access necessary care. But that was definitely a highly debated part of the bill, and something that, you know, I'm deeply afraid will keep a lot of people from seeking care because many people are in the same exact position of not having that extra income to afford that cost sharing, which is the whole point of having Medicaid, to make sure everyone has access to that care.
I just was really concerned about that myself because I see a lot of different doctors and I could see that being really costly for me.
Absolutely. It's concerning, and I encourage you and everyone else to continue advocating and talking to the state to make sure that that's minimized as much as possible in Michigan. Michigan's going to have a lot of say over how this is provided and implemented with the people in Michigan.
Did they ever say why the IDD was not included into the exemption?
I don't know. I don't have more information on that. I'm not sure how the exemption got structured. I'm sorry.
Right. I think we have one more question in the room, and then we'll move on to our next speaker.
One
No?
more question, Hannah.
Can you hear me?
Okay.
All right. My name is Kathleen Kovach. I do have a question relative to Michigan and the provider tax that leverages Medicaid. Could you speak to that issue as it relates to the current changes to Medicaid?
Yeah, so a big part of this change is changing how states pay for their portion of the Medicaid program, and the provider tax is used by every state except for the state of Alaska. And so that's going to greatly reduce resources for the state. Providers across the state help cover that cost, and it ensures that people have access to Medicaid and have access to services. And really, it helps make sure that that federal money that's a match for Michigan's money comes into the state. So that the provider taxes are being capped, so states can't create new provider taxes, but they're also going to be reduced over a period of years by 0.5 percentage point. So it's not going to have necessarily, that provision will not necessarily have the biggest immediate impact, but over 10 years, it's going to have more of a substantial impact as the amount that those provider taxes can equate to goes down, I believe from 6% to 3.5%. So it's going to have, over the long term, is going to have a bigger change. And, I think there are a lot of groups that are working to try to, I think there are groups working to try to overturn every part of this bill, but I know that there are a lot of groups and particularly a lot of provider groups who are working to try to mitigate that and reduce the impact, knowing that it'll impact their overall Medicaid eligibility and the pot that the state has to provide Medicaid services.
Thank you, Hannah. I'm going to, and again, sincerely thank you for your expertise and participation today. I'm going to turn it over. I think the next speaker is Alan, but I'm going to just make one comment. To require a person with an invisible disability to prove that disability is egregious to me. So whether it's someone who lives with a substance use disorder or a mental illness, let alone folks who are living with intellectual and developmental disabilities and on the autism spectrum, I urge you to continue to advocate by reaching out to your state and federal legislators who are supporting this legislation. It's easy to reach out, and I'm not getting into politics. I don't care if you're a Democrat or Republican. But if you know who's supporting this legislation and you know it's going to be harmful to either you, your loved one, someone you're a caregiver to, or to the community at large, it is our collective responsibility to reach out to those individuals and help them understand the negative impact it's going to have on these communities. I was in Washington, D.C. back in, I think it was May or June, Hannah, when we made our Hill visits. And I have to be honest with you, it was one of the most disheartening Hill visit experiences that I ever had, because those who are supporting this legislation just dug in, and it was almost like they weren't listening. It's either they don't understand even their own constituency, either you don't understand or you don't care. And it's our responsibility to make them care. So if you take nothing else from me this evening, it is our responsibility to continue to advocate on behalf of the people we serve and we love. Alan, you're up.
We're going to save time. Alan really doesn't need an introduction, but Alan is the executive director to be. Right now he's the deputy or vice director of the Community Mental Health Association of Michigan, who is a strong advocate across the entire state. So thank you, Alan, for being with us today.
No, thanks for having me. It was a great overview from the federal perspective. So I talked to a lot of folks about the PIHP procurement. As you can imagine, all across the state, I've talked to dozens and dozens of legislators on this, so I'll kind of give you my little bit of a rundown, and I may be all over the place because I have a number of issues that I'd like to raise just to kind of put on your all radar. I guess the first thing that I say when I go and talk to groups about this is I think when I talk about we, I mean our state association. So we represent 46 CMHs, all 10 PIHPs, plus 100 plus provider organizations. We have a whole bunch of our membership that is open, willing, and looking for some kind of a change for the better for the public mental health system. And I know Kevin with other advocates certainly support change to the current membership that is open, willing, and looking for some kind of a change for the better for the public mental health system. And I know Kevin with other advocates certainly support change to the current system. And there have been a number of attempts to kind of get us to move in the direction that the RFP is taking us down. But I think the biggest problem with what the department has put out through their RFP, I believe, is the process. This has been very much a behind closed door process. It has not been transparent, has not been in the open. For better or for worse, what Senator Shirkey wanted to do in 2022, where he wanted to essentially do the same thing the department is proposing now, at least that was done through the legislative process. They had committee hearings. He had people in his office. It was open. It was transparent. You could see the language. You knew exactly what he was intending to do. Again, this is being done behind closed doors. The department, through this entire process, which essentially launched the end of February, when they put out a press release, they also put out a survey that said, we want to get people's feedback on the public mental health system, what's good, what's bad, and that may or may not influence us as we move forward with a competitive procurement of the PIHP system. Then, a little bit later, a few months later, May 23rd, then they put out another press release that said, yes, we are going to move forward with a competitive procurement. We had 2,600 people that responded to our survey that we did back in February, and it very clearly showed that, yes, we need to do something different, and we're going to move forward. And then now, August 4, the department issued their RFP, which, by the way, is due in 41 days. So it is a very quick, from when they announced it to when it's due, September 29th is 55 days. So it's 41 days from today that responses are due to that RFP. But again, I believe that the process which they're going about doing this has been the problem all along. In 2014, we had 18 PIHPs across the state. We ultimately ended up going down to 10. But at that time, the department literally, and I was working with the association at the time, literally came to our office and said, we want to have fewer PIHPs. Here's what we want to do. They kind of articulate, we want to have fewer, we want to do this, we want to do that. They literally came to our office, sat down with all of our members and said, okay, here is our plan to get to fewer PIHPs. And we went back and forth through a few meetings and were able to work out, for better or for worse, the 10 PIHPs that we have currently. I think the department originally put up like a map of maybe 3, maybe 5, and then we ended up landing on 10. But that process was, very much in the open, had all the key stakeholders at the table, were able to work it out, did not have to go through some kind of a competitive procurement process. I very much believe that the procurement process strongly favors the private insurance companies in that process. And I'll touch on that in a little bit. But again, through the current process, the department has basically picked and choose who they wanted to get feedback from. That kind of shaped the questions they put in the survey to some of the quotes they had in press releases. They were kind of picking and choosing who they wanted to listen to as they move this forward. My members, the folks that I represent, which OCHN is one of them, I believe very strongly that they are part of the solution. They very much have to be at the table, working with the department, with Kevin, with the other key stakeholders to figure out basically where do we want to take this, how best to get there. I think the end product would be far better than what this current process is taking us down. Now, because this RFP is out, any question that we have of the folks at MDHHS, they cannot answer now because there's a procurement out there. They can't take questions. We have to direct questions all through a middle person at the Michigan Department of Management and Budget. They're the ones that take questions on the process, but they are not able to kind of take any kind of a feedback, a back and forth. I mean, there are a million different little strings that if you pull on here, 6 other problems pop up that they have not thought through all the different scenarios of what the impact this would have on all of you in the community. And that's really, I think, again, this process has really lacked as far as transparency and the department being upfront. So again, I believe that going to an RFP very much in favors the private insurance sector in this. Just from a pure competitive standpoint, OCHN, the way that they are currently constructed, Macomb County Community Mental Health Agency, the way they're currently constructed, DWIN, the way they're constructed, are not able to bid on this RFP that is out. Right now, the private insurance health companies do not have to build anything new. They can bid on this as they are. Any of our public members have to come up with a new entity, a new structure in order to bid on this. And again, when they give a window of 55 days, that's 55 days that you have to put something together to put a bid out, again, gives a very strong competitive advantage to those folks in the private sector. And again, I've got a list longer than my arm of problems of if this does get in fact turned over to insurance companies, the overhead is significantly higher. It was a good lead-in with the impact of what's going on at the federal level. In fact, the one big beautiful bill that was passed in Washington, D.C., that is going to have a $1.1 billion impact on the state of Michigan beginning in FY26. So beginning of October 1 of this year, there's going to be $1.1 billion less in the state of Michigan to spend because of that. Almost $700 million of that is because of the tax changes, the corporate tax changes, the no tax on tips, the no tax on overtime, all that kind of stuff. The other part of that is to Kathleen's question on provider taxes. One of the provider taxes that Michigan is absolutely going to lose once that bill goes into effect is the IPA. It's the Insurance Provider Assessment Tax. That is paid by OCHN pays that. All 10 PHPs pay into that. The Medicaid health plans pay into that. That tax generates about $600 million for the state of Michigan. The state of Michigan uses about $450 million of that to draw down federal match for Medicaid. That's worth probably $1.7 billion to the state of Michigan's Medicaid program. That is going to go away from that legislation that was passed. So that means that the state legislature, they have to come up with the $450 to $500 million to maintain status quo so we don't lose those Medicaid funds. When we talk about the impact with the federal level, this is a 1-2 punch that people in the public mental health system are going to be taking, where the state is already losing billions of dollars from federal Medicaid cuts. If this in fact does go to private insurance companies, you could be pulling out almost another $500 million just going to their higher cost, their overhead. Their overhead is anywhere between 10 and 15%. Our public system is 2-5%, something like that. When you talk about $4.5 billion, that is several $100 million a year that is just poof gone, does not go into direct services. So that is terribly problematic. Also, with the map that was put out, do not be fooled. The department is not intending to go to 10 PHPs down to 3. They're going to have 3 regions. They fully intend to have multiple entities. They intend to award multiple entities per region if they have bids. So here in the Detroit metro area, my guess is you will have anywhere between 4 to 6 health plans bid on the contract here. So you could have not one managed care entity here in Oakland County. You could have 4 or 5 or 6 of them. Every entity that you add pulls money away from services. They are sucking money away that is not going directly to services. And it adds bureaucratic layers and this and that to that. With folks from the Board of County Commissioners, if this does get turned over to an insurance company, they're going to end up calling a 1-800 number and talking to someone in God knows where about the issue, where at least here now, if an individual has an issue with OCHN or Macomb or Detroit Wayne, they can go to their local Board of County Commissioners and say, hey, I have a problem here in Oakland County. Can you do something? There is a level of accountability, local voice that will be lost if this goes to private insurance companies. There are, again, a whole host of problems, not to mention the fact that individuals that receive these services have said over and over again, I do not want my insurance, I do not want my specialty behavioral health care services provided by an insurance company. I don't want it. I mean, they've said it over and over again, and the department is choosing to ignore that and go around the will of the people. I've heard, talking to a number of legislators, both sides of the aisle, I think the legislature is concerned about this, that, the department is essentially circumventing their role in this whole thing. They believe that they don't have to change state law. They don't need the legislature. They can do this through contracts, through executive power. It is very problematic that they are doing this around the legislature, that they are not involving them in this process. Ultimately, we'll see if they do have to change state law. We also have concerns where this not only removes the PIHP system, this will dramatically impact CMHs as well. In the RFP, it talks about delegation of functions and what the entities have to do. Our CMHs, now they're a little bit different here in the Metro Detroit area because they're both entities, but our CMHs do far more than just provide services. I mean, they manage networks, they manage contracts. They have a very specific list of things that they are required to do that is put in Michigan law, in the Michigan Mental Health Code. This RFP kind of ignores that and just says, well, you don't have to worry about that. Here's how this is going to work. Again, we'll see if they have to change laws or not. But again, that is very problematic the way that this is laid out. We do know because we FOIA'd the survey results from the February survey and wanted to know, one of the questions was, what are the biggest challenges the current system has, and how would you like MDHHS to address it? Number one was workforce. Provider shortages, especially psychiatrists and then clinicians in underserved areas. Fiscal and administrative transparency, crisis services, long-term care options, funding allocations, client rights. Those are what people were saying in the survey of what they want addressed. I mean, at least, we have like the top 10, but there was no, well, let's competitively bid the PHP system and let's change who's actually paying the bills. Again, in my opinion, I don't think people really care who's paying the bills. As long as the bills get paid on time, they want choice of provider, of who's providing their services, not who's paying the bills. Again, we can go through in the question and answers if folks have questions, happy to answer questions. But one of the slides that was put up, the Walk a Mile rally that we have in September 17th in Lansing, our keynote speaker this year is going to be Senator Stabenow. So we've been working very closely with Debbie Stabenow. She is very much opposed to what the department is proposing to do. She is very fired up. She's working with us, working with Kevin, a number of our other allies in this. We have the Michigan Association of Counties. We have the Michigan Catholic Conference, a whole host of folks from labor, ACLU, NAMI. A big group is really concerned with what the department is proposing, but Senator Stabenow is going to be our speaker at the Walk a Mile rally. So hopefully that we're really intending to turn that into a anti-RFP privatization rally at the Capitol. Hopefully it's not too late to stop the RFP. And again, we are not saying status quo. Let's stop the RFP, go back to status quo. We are saying, we are willing to roll up our sleeves, work with the administration, with other stakeholders, make necessary changes. But again, the process is the flawed part of this, not the end result. Noon. Yep.
Okay, are we to question and answers, or do you want me to wait?
Oh, you got it, okay. I'm curious, what is the RFP asking you for? No one has really stated. Is this for a proposal for an overhaul of the system?
Yeah.
Does the winner come down to price then, based on your creative proposal back on what Michigan needs?
I mean, that's a good question. So the RFP, they actually have a scoring process in there where they award points. But again, lack of transparency. I mean, this is being now graded by someone in another department based off of the responses. The RFP is 432 pages.
Certainly. Well, in a traditional business, right?
Yeah.
And that's how I'm viewing what it is that you're saying now, because I have to, in my line of work, I have to supply RFQ replies all the time.
Exactly.
You're typically allowed to request, A, an extension of deadline, B, a conference call where all suppliers who are asked to bid on the process get on the phone and can air out their questions so that even though you have a mediator who's supplying the RFQ, you still get answers back from the originator of it.
So to answer that question, we did have on last Monday, there was a 10 a.m. rate setting meeting that lasted about 30 minutes. And then there was a bidders conference at 1 o'clock that the department went through some slides that literally took 15 minutes. That basically gave folks an overview of this is what's in the RFP, and that was it. Mm-hmm. We have until Wednesday at noon to submit questions to the RFP. The questions will be answered by August 29th. So we have between now and Wednesday, but when this came out on August 4th, you had between August 4th and August 20th to submit questions in writing regarding the RFP. So that's the process that we are in now. Then the responses to those will be out on August 29th.
Can you guys recommend a intelligent solution for consolidation?
Yeah, I mean, absolutely. If they would sit down with us,
no, not in any means, right?
Yeah.
Like I know you guys have
absolutely
partners, right?
So, yeah. I mean, we would absolutely be willing to sit down with the department. We want to go to 3, 4, 5, whatever. Here's what we want. Here are the goals. They've never really have articulated what exactly they're trying to accomplish by doing this. I mean, we kind of hear some different business back and forth, but they never have really articulated, strongly of here's where we want to go. We'd be more than willing to sit down with them and work on that. Keep in mind, timing of this. If these contracts go into effect 10/1 of 26, that's 30 days for the next election for the next governor of the state of Michigan. That's 90 days before the folks that are making these decisions now are no longer going to have a job with the state of Michigan. That is extremely troubling, where they're going to set up a system where they are not going to be held accountable for the end result because they're going to be long gone, and the folks in the legislature and whoever comes in next is going to have to deal with this for probably the next 2 to 4 years, unraveling whatever kind of mess they create.
Thank you.
We have a question in the back. Go ahead, Christine. Right. So I want to, and I'm
sorry, no question.
Hi, Ellen. It's Christine Burke, Oakland County resident. I'm glad you touched on that accountability piece because I want to transition from transparency to accountability and going back to when 298 first came out. And one of the conversations we had was the validity of the survey itself. So CMS requires that its contractors submit correspondence writing communication at below an 8th grade level. The National Institute of Health recommends it's between 6th and 7th. The average reading level of a Medicaid enrollee is 5. When that the first 298 came out, we did challenge the survey itself at the time, and then Governor Snyder stepped in. He appointed then Lieutenant Governor Calley to pull together the work group, and I'm going to let Kevin fact check me on this if I'm off in any way. And we had 100 people that came together. So I have 2 questions, really. One, how do we challenge the validity of the survey? If they're going to lean into that survey and say, this is why we're doing the RFP, I would all day long question, I took the survey, I guarantee it's not between a 6th and 7th level. And when I look at what we do in Oakland, we do smiley faces, we do long version, we do short version, we do simple answers. Me, not me, happy, not happy. I didn't see any of that in this survey. So holding them accountable from that aspect. But the other side, even going further to your point, what and how is it seen ethical that they're going to implement something and then they're gone? Mm-hmm. That, for the governor, to me, is the opportunity to step up and say, we want our predecessors to be successful. And I don't know what steps you take to engage her in this conversation about the validity of the survey itself, but then how do you ensure, as a leaving governor, that this state is successful?
Yeah. I don't think there was actually a question there.
There was, Alan, there was. How do we pull her in, Alan? How do we pull her in?
You contact the governor's office and let them know what the concern is.
I mean, it's been incredibly frustrating with the governor has her office has not been engaged on this. I mean, they have given a lot of control and a lot of power to Director Hertel, and it's. I mean, we've tried to engage the governor's office. I mean, that's why we've had folks like Kevin, all of our folks in labor. You had the Oakland County executive, the Macomb County executive, all send letters to the governor. All of our legislators trying to reach out to them. It's just not engaging in this. So I don't know what, I get it, in Lansing, I mean, they have, bigger fish to fry. I mean, they have other priorities that are going on, trying to get the budget done. They got a gazillion other things going on. This is not probably immediately high on the to-do list, but it's been very, very frustrating from our perspective to get the governor and her office engaged in this.
This is Fred Cummins. Couple of questions. First of all, I want to know who to blame for this. I would like a list of who the champion or champions are. I don't need any insurance companies. Don't tell me about them. I know where they are. But I would like to know who is involved, and particularly in the government, where it's coming from. Because I like to know.
Yeah. I mean, I think it's Director Hertel, who's the director of the Michigan Department of Health and Human Services.
That's the only one you can find.
And then her leadership team. But I mean, I would start. I mean, ultimately, it's
all anonymous.
The buck stops there with her as the head of the department.
So basically, they're saying they're all anonymous except for Hertel.
He's good.
The second is, I assume that the RFP is a document, and it's published somewhere. Where is it published?
It's online. Yeah, I mean I'm not joking. It's 432 pages.
I understand
long.
That.
But no, it's online. I don't exactly know where it's housed, but we can.
So it does have some kind of requirements. It's 400 pages of requirements, presumably, or just thoughts.
Yeah, no, I mean, it has a proposal instructions, it has a statement of work, and then there's a whole narrative that you have to fill out as you submit your response. And there's a whole bunch of different...
So does it actually come down with the requirements, or this is all about how to do the process?
No, I mean, there's requirements of who's eligible to apply and, what...
So what they're going to do.
Yeah.
What they're going to propose. A requirement. I mean, if nothing else, it says, what's the system that you're proposing?
Yeah, I think what it is, again, they believe they're keeping the CMH system intact, and they are changing the number of, what they're still going to call PIHPs.
Well, none of the PIHPs can't propose anything. They're not changing it.
No, they're calling these new entities PIHPs as well.
Well,
so.
All right, I think we have a couple of questions online as well. So if you have your hand raised online, you can go ahead and open your mic and ask your question.
Hello. My name is Matthew Fitson. I'm from Oakland County. I'm an individual served by Oakland County community health network. And I have a couple questions. Yes, you can get direct caregivers through Medicare. I'm reading online, but what if some of the individuals don't have Medicare for some reason, and they need those help? So now you're putting us into private entities that not going to care for us to make sure that our needs are met. That's what I'm afraid of with this whole new plan that they're trying to do. And it's very dangerous. 298 or whatever the heck it was a couple years back, they heard it from everybody. So I don't understand why they are going backwards to Shirky's bill, basically, and starting all over again. It's ridiculous.
That's a good question. We don't really have that. That's kind of the $10 million question. Yeah.
Alan, this is State Representative Noah Arbit, representing the greater West Bloomfield area. I do want to disagree with you on one point. This actually has been a huge topic of conversation in Lansing, and at least I can speak for the Democratic caucus. This is something that we are intensely engaged in and want to continue to be intensely engaged in, something that I think many of us are incredibly concerned about on a number of fronts, some of which you mentioned, obviously, cutting out the legislature, doing this and then sort of around the legislative process, but also just substantively in terms of what this is going to do to, to the status of care and access to care for people, local control. A lot of what you mentioned. I was impressed and gratified to hear that Debbie Stabenow is being brought in as someone almost like a surrogate to sort of speak against this. And I would respectfully submit that I think one of the things that we are lacking right now that is intensely needed at this moment is public opposition and drumming up public opposition. Obviously, this is sort of an arcane and difficult to explain issue. And so if folks can be engaged to work on the messaging front, so that way, I'm on Let It Rip all the time on Fox 2 News, that, this is something that we can, sort of drum up in the media and get the media to talk about this and build that opposition. That's how we, and obviously Debbie Stabenow as a, big voice in our state can be a part of that. Other stakeholders can be, and big people can be leveraged to do that. That's something that I think we need. And we also need very, very clear talking points to be able to distill, so I can explain to my constituents what's happening in, sort of a 4-bullet point list way, in a way that's going to get them angry and engaged to, contact the governor and say, what the hell, why are you doing this? And why are you going around the legislative process? And I think the other thing that I've sort of heard, and, I know this is a public forum, but, what the hell, I'll say it anyways, is that the Director Hertel is sort of angry at some of the PHPs for not signing their contracts and for, I guess, negotiating too hard with the state. And so she's just sort of solving the problem by, by forcing the bids open. And so that's something that I've heard, just as sort of an answer to your question of like, MDHHS has never sort of explicitly stated what its policy goals are for making this change. Well, I don't know that it has any. It seems to be a sort of reactionary step, right? And, and I think your point is well taken about the fact that, these folks who are, making this change right now are not going to be the next administration, regardless of who wins the next election. And so I think that's something that we really need to work on, and we have a very short window to do it, is, sort of this public advocacy campaign and getting folks really engaged, because, I see some of my constituents on here that I know that it's going to affect them. And I know that's the case for not just Oakland County, but people across the state. So let's continue to work on this. I know there's many folks in the legislature, myself included, who want to be part of the solution, who want to be agitating against this. So let's continue to engage on this. Thank you all for being here and for this forum.
Yeah, no, thank you, Representative. And Representative Arbit has been a strong supporter with us. And, we've had some interactions on this particular issue, and he's been a very vocal voice in opposition, and certainly appreciate that. Gentleman right here.
Is this on? Yep. My name is Bob McCreevy. I have a son that's been in the mental health system for like 37 years. Prior to COVID, in this county, we had I belong to a NAMI group. There's 4 of us here tonight. NAMI of Oakland County, we have an office in Southfield. Prior to COVID, we put on mental health town hall meetings, and we had, I believe, 3 of them working with your offices here, and we held them in the Beaumont Hospital auditorium. And all of the legislature in Lansing knew that we were doing this. They were all invited, as all of you were invited, and the public. We had an open mic, and we talked about the good, the bad, and the ugly. And it made great meetings. And we made enough noise, all of us together, the strength in numbers and power of people, that Shirky, our friend over there, he couldn't get enough votes, hold enough votes together to privatize it, even though he was determined he was going to do it before he term limited out. So that, at that time, the noise that was made this work. It was power of people.
We had 11.
And we had 11 total town hall meetings in Oakland, Macomb, Wayne, and Monroe that were similar to what we did here. And many of the legislatures showed up and came to our meetings.
Thank you. I think we have we'll do one more online, and then we'd like to hear from the rest of our speakers, and then we'll have an opportunity for some questions at the end, hopefully. Okay. I think there's one person. I know there's 2 people that have their hand raised online, but we'll take that one that was up before, and then we'll save the rest of the questions till Q&A. So you can go ahead. Number 1.
My question is, hi, my name is Shaniqua, by the way. My question is, anybody realize what people with disabilities have to go through on a daily basis? And it's not fair for people with disabilities have to deal with the insurance getting cut. Is not fair because nobody's gonna be able to pay to go to a doctor or anything, or go to the hospital and pay hospital bills.
Thank you, Janiqua. Appreciate your comments. Agreed. Next, we have Commissioner Spiz. Commissioner Spiz has been a commissioner since November of 2012. He is a very active member of our organization and the community at large. He serves on our Oversight Policy Board, and that is all you need to know. He is very active and engaged and supportive of everything we do. So thank you for being here.
Thank you, Dana. Good to see everybody here today. I'm going to cut mine short a little bit because I think Alan did a bang-up job going through all those details and a few of those topic points, highlights I was going to hit on anyway, but I may emphasize them at the end. So what I want to focus on is my interaction with OCHN. I've been on the board roughly 12, 13 years, and probably 10 of those I've dealt with OCHN on one way or another, on a board here, a board there. And there's some of the key programs that we work closely at the Board of Commissioners, and I do personally with OCHN, right? And what's good is I can just pick up the phone. I can call Dana. I can call Trish. I could have called Christina and say, hey, let's let's work on this project. Some of those projects are the CIT program, right, which is one of my favorites that we're still pushing through, and we've continued to push through. Navigator programs, right? And probably one of the ones that's near and dear, actually two of them, but one more than the other, near and dear to my heart is the Oxford incident, right? My daughter was in the school that day. So I am very proud of what the staff and everybody here at OCHN did to help that entire community during one of the hardest times that they've ever been through. And then you had the recent Rochester Hills one, same thing, and they're still supporting that community today. And one of the other ones is the co-responder program with our police and first responders out in the public. Instead of putting people in jail, let's give them the care that they need, right? And we at the Board of Commissioners have worked through funding on some of these to get them funding through ARPA money or other ways because they're important to the Board of Commissioners and to a lot of people out there in the public. So I really would hate to lose that. Ellen shed some light on, I wouldn't be dealing directly with OCHN in some of these cases anymore. I'd be going to a business. Do you think a CEO of a big multi-billion-dollar company is going to answer my phone call? Hell no, they're not going to pick up that phone call, right? I'd be lucky if I can get to their admin. So do you think something we turn around pretty quickly on many occasions would happen? The red tape at some of those organizations is going to be worse than government. And in many cases, people hear me say government moves at glacial pace, and they do in many cases. And to touch on this topic in particular, the RFP, there is a political spin to this somewhere. I haven't figured it out yet, but there is. There's only certain reasons they push things through at the 12th hour. There's only certain reasons they don't give you all the information, right? Right. It's usually money or power and control. Right? Somebody wants X to happen. They push this through. They don't tell you all the details. Yes, they put an RFP, and that's actually probably the best thing. It's an RFP. It's not an RFQ, right? It's an RFP. So hopefully we'll get some proposals about this. But I'd like to reemphasize, call your legislature. Call the governor. Because if there is enough stir up about this, you can stop it. We can stop it. Because I still believe to this day, somehow it's going to have to go through the legislature. And Alan touched on it. They still haven't approved their budget for this year. And some of my insiders are saying that probably won't be done until October 1st or end of September because it's due October 1st. And the way to control stuff like that is through the budget because the legislatures have the power of the purse. Okay? And they can shut it down. If we get enough people talking, they can shut it down. Yes, they're focused on budget right now, but somehow this has got to be a line item somewhere, especially after what we just saw. Hannah present. You got $1 billion you have to find. And then you have this. And if everything's true, that's going to actually cost us more money because of administration fees, which I can see it happening. Where's that money coming from? Right? So call your legislature, call the governor, right? And be loud and proud. Thank you.
Any questions for Commissioner Spiz? Oh, we do have one up front.
Not, I don't like this or this doesn't seem. Is it really to narrow down on this process wasn't legal or fair or right?
I would say yes, because I think without having the input from all the PIHPs out there, how are you making decisions? So it goes back to the point, what are you trying to hide or what are you trying to get accomplished? If you don't bring people into the table that really know what they're talking about, right, about this entire process, okay, yeah, you want to make some changes, which some were done in the past. You just don't invite them. You invite people to the table that you like their answers, right? Like-minded people, which is not the way to get a truly effective and efficient system or process put in place.
298 was the previous attempt to do
Correct.
this, right? And that was put through the process and did not get
Right,
voted
because
in.
nobody liked it, right? Right. So, but if you get everybody to the table and you guys we can all come to an agreement on what would be effective and efficient for everybody out there, everybody that needs this care, that is the best way to get it. Is it going to be the cheapest? Maybe not. But that's not always the goal. The goal is to get the most effective and efficient care for everybody that needs
Based
the
on
care
the
out there.
survey that is what they were asking for, right? So if this whole RFP was supposedly somewhat initiated by the survey.
Correct, and Dana and I were having a little sidebar here. To me, based on what Christine said, if somebody was going to happen to file a lawsuit against somebody, I would go after the survey first. That would be my recommendation.
Thank you.
You're welcome.
Go ahead, Kathleen.
Hello. Hi, I'm Kathleen again. Thank you so much, Commissioner, for providing us your viewpoint. I like to attend local legislative coffee hours. And one of the things I've said when I've gone to them, and they're wonderful because you get a lot of face time, one of the things I've said is when you have changes at the federal level and at the state level, they translate into changes at the county level. And so I always say, with these changes, what is the responsibility of local legislators and the county commissioner to do a contingency planning or an evaluation to talk about how these changes translate into services and supports for people in the county and the community, and how are you going to address that, and then how are you going to communicate that to your community? So I guess I would say to you, from the viewpoint of where you sit and this change with this RFP, what kinds of talking points could we take to the local county commissioners, the local legislators, and talk about these issues? I guess maybe there might be the 4 points, talking points, but really, how do we address that to say, hey, isn't it your responsibility to do some strategic planning and implementation with these changes? Am I off base, or help me to understand what the role is of the county commissioners and the local legislators?
I don't think you're off base, because we have a close working relationship with, like I do with OCHN, or the entire Board of Commissioners does with OCHN. So I would say each Board of Commissioners across the state of Michigan should be having that same conversation, right? We issued a resolution against this RFP, as did Executive Coulter, as did, I think, Executive Hackle, and some other ones, but putting out just a piece of paper doesn't necessarily work, right? And I think Representative Arbit touched on it, is getting the press and other people to grab onto this, because there are a lot of topics that you probably all see in the press that last one day, right? And then they disappear. We need to get this in the press and make it continue to be in the press over and over and over and over again, so people hear it. You know, I can tell two friends and they could tell two friends, and we can go through that, but are they really listening? Are they really paying attention, right? So that's where we need to get people to really pay attention, and how does it truly affect them and their families, their neighbors, et cetera, and their entire community for that matter. Because a lot of people don't necessarily understand what is in this RFP. We can go out and say there's an RFP 1, 2, 3 out there, but they're not going to go read 432 pages, right? So you need, like you said, you need to summarize it into like 4 or 5 bullet points and have those conversations with the county commissioners, their families, the community, but we need to get the press to jump on it.
Thank you very much.
You're welcome.
I've had some experience in some rural areas, and they usually have the local newspaper reporter there. So I would say, if anybody's listening across this state, please find those talking points. Maybe the association and others could provide them, but go to those meetings and speak up, because you will not only talk to your legislators, you will talk to your local media. Again, thank you. I appreciate it.
Okay. This young man up front.
I have done a lot of lobbying. I have a self-driving car. It knows its way to Lansing. I've been there so many times. But I have a suggestion, and I've seen this done before. How about if you look up the governor's telephone number? You got 75 people here, and ask every one of us to call the governor's office and leave a message that we were here, and the consensus was, please do not privatize the mental health system, and register your call on her phone. And you can do that before you go to bed tonight.
Love the idea. We have 122 people on the phone too that can do the same thing. Dial her up, blow up. I would not only blow up her phone, but your rep's phone too. It does work.
Okay, one more question.
somewhere. There we go. Yeah, I think one of the key issues you point out is we're talking about accountability here. We're talking about somebody who's changing the system in an undefined way, but certainly irresponsibly, and they're not accountable. But let me ask you another question is, CMS, Center for Medicaid and Medicare, is in charge of the system with Medicare and Medicaid, particularly Medicaid and mental health is a mess across the country. And it's been that for a few years. And there's no accountability. They just kind of hand out regulations and they turn things on and say, well, why don't you try this? And things go crazy. And every state's done crazy stuff. And they just sit back and say, well, here's your budget. Get along with it. I don't care how much you need. Here it is. So in turn, it goes back to Congress. They're not accountable either. They just let CMS get away with all this crap. And here we're out in the states trying to figure out what to do with something that's totally not enough to deal with the real problems. So I suggest we also need to be going back to Congress and CMH and Medicare and saying, well, where do you guys stand on this? You're responsible for it. Stand up and tell us why we're doing this, because you guys are in charge. They are in charge all the time. They're causing the problem everywhere. And they don't care.
Thank you so much. We appreciate all your comments. We're actually going to skip ahead to Amit. He is our person served. Go ahead, Dana.
Thank you so much. Like Suzanne said, my name's person served. My name's Amit Adwal. So basically what I want to briefly talk to you about today is, keeping services local and public. I'm a person served. I have received services through the system for many years, and I have a lot of needs. And if the system gets privatized like it's being proposed, I won't be able to easily, explain my needs and get access to services that I need. So it's really important that services stay local and stay public. So, like all the presenters before me have said, talk to your legislators, make sure that you, advocate as much as you can, because keeping it local and public is extremely important to save the quality of services here in Oakland County and actually throughout the state. So keep it local and public. Yep.
Any questions for Amit? Thank you so much, Amit. Amit didn't even give himself enough credit. He's actually one of our trainers, and he is well sought after as a trainer in our system. And so thank you so much for being here and telling your story.
Thank you, Dana.
And next, we'll switch over back to Deidre Goldsmith. Deidre Goldsmith is representing the substance use disorder provider testimonial. She is actually a partner and provider of clinical services at Therapeutics Incorporated. She's been around for 30 plus years as a nurse and anesthetist, thank you. And so she not only provides the services, she actually is hands-on and very, very much involved in the commitment to making sure that people have recovery services and supports in our community. So I want to thank her and her husband, who's here as well, an administrator at Therapeutics, for their commitment and dedication. And actually, they know Commissioner Spiz very well because they come to our board meetings. So that's what it's about, the partnership between our providers and ourselves and working closely together to make sure that we continue to be a community mental health system for this community and have the ability to drive our priorities. So I want to pass it over to Deidre. Thank you.
Thank you, Dana. As a provider, well, in talking to all the providers, we're as nervous as the PIHPs, even as the clients, because we don't know what's going to happen. Sorry. So we don't know what's going to happen either. We try to service our clients as best we can and keep them calm about it. But two perspectives come out of this. And what's going to result in better treatment, and which environment will enable providers to be more effective. Those are the two things that we're really concerned about. Now, there are 6 things that are advantageous to the current system. And our panel has talked about how the local voice is very important. It's very important for clients to be able to have a voice in what their problems are. It's integrated and it's tailored care, so the PIHPs have relationships with local providers and they understand the community. We don't know if that's going to be intact if private insurers come around. There's strong accountability and oversight. The PIHPs are public entities and they're very sensitive to county governments. Also, they reinvest in the community. Unlike private insurers, Oakland County Community Health Network continuously looks for ways to expand services. I know that our clients, especially in substance abuse, even though we're outpatient, they have a lot of needs. Some are homeless, and they still manage to come to our clinic. Transportation is a big issue. Mental health is a big issue. Care coordination, that's another thing that OCHN is very strong about. We need to coordinate with mental health as well as even jail MAT. Am I not talking? You got up. But there's a strong focus in that, and especially substance abuse in the criminal justice system. That would be pretty difficult for private insurers to do, I would think. Lower administrative costs. Now, I think that overall the system has work to do, but I think that Oakland County is they're open to reducing these costs. I don't think that's going to happen with private insurers. I mean, they're for profit. OCHN is more on the not-for-profit model. So there's going to be a lot of changes there. OCHN has also been supportive of our innovation. Therapeutics has developed, it's an R3 model of a quantitative way to measure how well a client is doing in treatment. If you think about it, this doesn't exist across the board. And they have facilitated us with grants and helping us to coordinate this such that we're trying to make it an evidence-based model to use nationwide. So all of these things, Oakland County Community Health Network has given us support, not only to be better providers, but they've given us that guidance of how to be better providers, the evidence-based models. And if it were a free-for-all, you may not have that. So there's a lot of gray areas that are happening, and we're listening to our clients. We're trying to calm our clients, and we care for our clients. So this happening, we can't cut them off, but we don't know what's going to happen and what will become of this whole structured network. So anything we can do as providers, we're willing to do it. All I have.
I'm not sure, was Dutton Farms available to join us online? Oh, great. Okay. So our next speaker is Jenny Brown. She's the founder and CEO of Dutton Farms, a nonprofit organization dedicated to empowering adults with disabilities. She co-founded Dutton Farms with her mother and has been instrumental in creating an inclusive program that helps individuals with developmental disabilities participate in the workforce and communities. And what I can tell you personally about Dutton Farms and Jenny Brown and her family who provides this service is that just go and visit Dutton Farms. You will be drawn into the amazing services and supports that they provide to individuals in our community. And then just the other thing, constantly advocating for the community mental health system. And so with that, I'll pass it over to Jenny and say thank you for being here with us.
Thanks, Dana. There's a little bit of reverberation, so bear with me as I try to make my way through that. So I am the CEO of Dutton Farm, a nonprofit organization based in Oakland County, dedicated to empowering and supporting adults with developmental disabilities by providing skill building and workforce development services since 2010. This year alone, we have delivered nearly 65,000 hours of skill building and job coaching services, along with over 30,000 rides for meaningful community engagement into the community. One of our pillars of community engagement is volunteerism, where individuals with disabilities have contributed almost 1,200 hours of service in various roles this year alone, including initiatives like Meals on Wheels and the Bottomless Toy Chest. One of our proudest achievements this year involved a group of individuals with disabilities assembling 2,000 gifts for children battling terminal illness in partnership with the Bottomless Toy Chest. I mention all of this because these outcomes are possible due to the unique approach that Dutton is able to take based on the needs of our participants and community relationships that we establish. This is possible because of local oversight, local involvement, and relational equity from OCHN that allows us to be innovative and creative based on the needs of our participants. Furthermore, through our job coaching services, we have generated over $165,000 in discretionary income for those people with disabilities, empowering them to secure competitive employment in an integrated setting. Again, these outcomes are possible because of strong partnerships with OCHN and their understanding of our community and our needs. OCHN is uniquely positioned for local partnerships like Dutton Farm because of its relational equity with us and a deep understanding of the needs of its residents, people that we serve, that allows for more individualized service delivery with easier access from providers like us to those in governance and decision-making positions. Recently, when we faced a significant challenge, Dana made herself available and followed up with her team to resolve the issue that we were having so we could continue providing crucial services, which I am deeply grateful for, because if I have an issue now, there is a local voice and we have access to a local agency that will help us solve issues so that we can continue doing the work that we do. I'm concerned that if we lose, this bid goes to a private insurance agency, we won't have that kind of access. Additionally, some of the other concerns that I have regarding the potential privatization because of maybe goals of efficiency or cost saving measures. First is the administrative costs. Private insurers often spend up to 15% on overhead, while the public mental health system only spends 2%. This shift could mean more money diverted away from direct services, money that our already underfunded program desperately needs. Additionally, the volume of mistakes in the Medicaid redetermination process have resulted in severe funding disruptions, affecting the continuity of care for those who rely on our services. Let me briefly share the story of Shomei Means, a cherished resident of Oakland County for 38 years. She began her dream job as a courtesy clerk at Kroger in 2014, where her work ethic and friendly personality earned her immense respect. Her job provided her with not only financial stability, but the dignity of independence. She was able to purchase gifts for her loved ones and contribute to her local economy. However, Shomei lost her job due to the lack of a long-term job coach, and her struggle to regain employment has been exacerbated by being placed incorrectly on the family planning waiver that resulted in service gaps that she was entitled to. Still resilient in the face of adversities, Shomei has been determined to work. Unfortunately, the bureaucratic errors prohibited her access to Medicaid services. And over the past 6 months, extensive advocacy efforts have been made to rectify her situation. Thankfully, along with the support of OCHN, and government relations partners, we were successful in our efforts, but we spent an enormous amount of time and resources to rectify an issue that was created by a redetermination error at the state level. So until we stabilize this redetermination process, I recommend pausing any movement towards restructuring the public healthcare system to avoid any additional disruptions in care. As we look towards this RFP and potential privatization, I also worry about the future of smaller organizations like Dutton. How will we compete against larger entities that may benefit from streamlined administrative requirements but lack the personal relationships we've built with the individuals that we serve? With a model that favors consolidation, we risk losing the continuity and quality of care that our participants depend on. The administrative requirements will by default eliminate small but impactful providers like Dutton Farm that are community institutions that many have depended on for decades. I am also concerned about the process and level of transparency regarding these changes and what the impact will be to the individuals that we serve and the extremely tight timeline for the RFP to be due. I also think that to improve the public healthcare system, we need the right leaders at the table to determine what is best for the individuals we serve, and being at the table should be more than a response to a survey. Furthermore, the surveys that I saw were not accessible to many folks receiving services, and I have serious concerns with the survey and stakeholder feedback that is driving decisions, is quote unquote driving decisions. These decisions will have a profound impact on the lives of hundreds, if not thousands of individuals. I ask that the state focuses on the importance of recognizing the faces and voices of our most vulnerable citizens who trust us to protect their interests. Every individual deserves access to respectful and dignified care. Yes, we must strive for fiscal responsibility, but also ensuring that providers hold a high standard of service delivery and positive outcomes, which upholds the state's shared goal. Michigan Medicaid beneficiaries deserve access to behavioral health care services when and where they need. So together, I think we can make enough noise to stop this, like Commissioner Spiz said, shut it down, and really focus on, when we reach out to the press, humanizing the issue and getting it out through the right channels so we can get the right people to pay attention. Thank you.
Thank you, Jenny. Are there any questions for Jenny in the room or online? Thank you so much, Jenny. We appreciate your advocacy. So next, not at all least, is Pepper Cat from the Alliance of Coalitions for Healthy Communities. The Alliance is taking steps to ensure that prevention and treatment are provided. So in April of 2025, Pepper celebrated her 1 year at the Alliance. She is a certified peer recovery coach and certified peer recovery mentor. And she is everywhere, taking her job very seriously, walking the walk. She also participates and works with the Oakland County Crisis Response Unit, which many people don't know until they actually need the support and services that they offer. It's very important that people understand what resources and services are available. And when we look at this, we think about the maybe basic mental health services that any one of us could need or use at one point in our lives or another. But really, we are a specialty program. And so with that, I'll pass it over to Pepper, so she can actually talk about how this program impacts what she does in her life. Thank you.
Thank you, Dana. Hi, I'm Pepper Cat. I'm a peer recovery coach. So that means I'm a person with lived experience. I'm a person that has been in active addiction. I've been homeless. I've moved from state to state trying to figure out what active addiction was and how to get out of it. I wanted to talk a little bit about my experience around Medicaid and what it means to me and my family and the people I serve. I didn't grow up in Michigan. I grew up down south. I grew up in a state that does not offer Medicaid to individuals unless they are disabled or pregnant. I ended up a mother and married by the time I was 17. I had already started into my own addiction at this time. Living down in Texas, I didn't have any insurance. I was a low-income individual. I had dropped out of high school. I was working at Kmart. There was no Medicaid For me, well, during the pregnancy, I was on Medicaid, and as soon as I had her, the Medicaid was turned off. So I had no medical insurance my whole life. I was low income, and at times I had insurance plans, but when you live paycheck to paycheck, sometimes that $20 copay is too much to go to a doctor. So I slipped through the cracks for many years. I didn't have any therapy. I never went to treatment, never did outpatient. I lived in Texas, Mississippi, Florida. None of those states offer Medicaid to adults. I finally ended up in Michigan in 2010. By this time, I had already passed my addiction and habits on to my child. I finally found recovery myself in 2016 here in Michigan. I did it without any treatment, without going to treatment centers, which is not something to brag about. I did not go to the hospital. I detoxed at home, which is very dangerous to detox from alcohol without any kind of medical supervision. I did it because I couldn't afford the doctor. I couldn't afford to go to a doctor, and if something were to go wrong, I really couldn't afford that. So it was just easier not to go. Luckily, living here, I learned about Medicaid plans. My daughter was able to go to treatment. She was able to get out of her active addiction. With the help of her Medicaid, she was able to receive therapy. She was able to receive inpatient help, outpatient help. She now lives in her own recovery. You know, my addiction lasted over 25 years, and I didn't have any support. Living here in Michigan and having the support of Medicaid allowed her to get the proper help she needed and shortened the time she was in active addiction. And then it didn't stop once she was able to get out of her cycle of using. She was still able to go to the doctor. She was able to get her health back on track. She was able to get her teeth fixed. Medicaid carried her through that, and now she works on her own and she's able to pay for her own insurance plan. But without that benefit, she might not have been able to get where she is now. She might not have even survived to be able to get where she is now. I learned a lot about Oakland County, and living here, I tell people all the time about how great Michigan is and how lucky we are to have Medicaid. I don't think people understand how difficult it is if you've never lived in another state to not have access to any type of health care, any type of mental health care. People go their whole lives without going to doctors. I'm 49 years old. I was undiagnosed from several mental health diagnoses. There's a lot of physical things I deal with that I'm just now starting to take care of at 49 because I couldn't afford to go and get those diagnoses when I was growing up. I know here in Michigan, we have certain laws that require people with lived experience or their family members to help make these decisions. I think a third of boards require lived experience. I know here we're very data-driven and evidence-based. We have a lower overdose deaths in Oakland County than anywhere in the country. I think that's because we work so closely together and that we listen to the people in our community. We listen to what's going on. We pay attention to where people need support, and we focus on that to be able to elevate people and bring them up to a healthier baseline. The little bit of research I did, this new RFP process changing out to the private sector goes against everything as an advocate that I fight for. People over profit is what I say, and from what I understand, going to the private sector is the total opposite of that. Companies are legally and ethically obligated to act in the best interest of the company, not the people. So this is going to be money-based, not people-based. We're going to have people falling through the cracks, just like I did. From what I understand, there's going to be a lot of confusion if this does happen. There's going to be probably gaps in coverage. There's going to be a loss of control in our people's voice and to the care we get in our community. It's going to cause a lot of confusion for people that already have a difficult time navigating a system that's not always easy to use in the first place. And I do think that our voice matters. I think we do need to call and let our stories be known. And I did write down Governor Gretchen Whitmer's phone number if anyone wants to call her. It is 517-335-7858. That is Governor Whitmer's Constituent Services line, so you can call that number. And I always say people over profit, so that's where it's at for me. Thank you.
That was excellent. Thank you so much for your story, and thanks for the phone number. I think it's been dropped in the chat a few times as well. I'm going to let Dana close. Just a couple comments since we move things around on this thing, but I love how we improvise. I love all the comments, the stories, and feedback. Obviously, the big picture. Advocate. Talk to your legislators. I think we have another question before I go into a few little details. You want to go ahead and ask your question, or you have a comment? We'll do it real quick. Sorry we're running so late, but we really thank everybody for your dedication to stay with us. So much appreciated. It's a really important topic, so we're thankful for all your comments and your dedication. Go ahead.
My name's Lisa Kowalski. I'm a parent of a man with IDD and autism who's about 32 years old. I was involved with the advocacy around 298 years ago. We met in Troy and in a town hall style meeting with about 150 people in a room. We broke into small groups and we started describing what families need their system to do for them. And we were very comprehensive. That is the information we used for advocacy at the state. We didn't say, no, we absolutely must have this organization just the way it is. We said, these are the things our families need. This is what our loved one needs. And we described that idea of integrated locally providers. We described care coordination. We described public oversight. We described that we must keep self-determination and be able to select our own medical plans, our own medical providers, our own support staff. We described what a fiduciary should do right the first time, and that training should be an obvious process that everyone can understand. We described what you do if there's incorrect billings and how can it get resolved, that we know how to do it as self-determined people. We describe that whoever this is, that they always are our advocates for the people that they serve. And there was a whole lot more than that. But that is how those parents in the room got 298 stopped. We started describing these are all the things that are needed. And that time they listened to us. And it did take however many meetings this wonderful man in front of me said, and the kind of meeting I just described. So I would just encourage any parent who feels motivated to advocate right now, that they think about what they're going to say and describe what your kid needs, more so than really insist on what they should do. And maybe the system that comes out of all of this will be better than it is now. When that survey went through before, there were many people who described in their comments that they wanted an RFP because there is enough things not working right now. And so that was what my comment was. Think about how you're going to advocate when you talk on the phone. What is it that you're going to say?
Thank you so much. Really quick, because that's a really good segue of the QR code that we have on the screen, as well as there's some on your tables too. We want to hear from you. We want your comments. We want to know, I know we've got comments in the chat. We've got comments and questions that have come up throughout the conversation, but feel free to give those to us online too, and using that QR code, and then we can try to compile that and put that on our advocacy page. Visit our advocacy page so that you can have those resources to advocate. Also, if you need assistance in filling out this form, you can call our customer service line. We have a new line, just so everybody knows. That number is, here's another number, 888-847-0513. That's our toll-free line. So if you need assistance with any of that, please feel free to call our customer service line. And I think we have one more question or comment or a couple, and then we're going to let Dana close us out. And again, thank you so much for your grace, everyone.
Hi. I was hoping that maybe you guys could clarify something for me. So it's my understanding when policy comes up in conversations at the state level that is based off of evidence. So if we have the evidence of mental illness and the need for services with intellectual disabilities, but then we're looking at the cuts that are happening with caregivers and stuff like that, then we eventually over time end up losing that evidence because we don't have anyone tracking or assessing that need. So my question is there really any conversation of how we are going to eventually end up losing money through taxes?
You know,
honestly, I'm sorry, did that?
Oh, no, that's a great question because it's a good segue as well because we're already losing money. We have lost through the redetermination process and the errors that occur with redetermination, which impacts our future funding in Medicaid. We also are looking at federal cuts, and I don't know, as long as I've been doing this, and I'm sure the people around us could not tell you of a bigger threat to Medicaid than we're seeing right now.
Well, and I have always been taught to follow the money, especially when it comes to politics. So I understand the individuals served are going to be the most impacted. Then we're looking at the direct care workers, and we're looking at everything that bridges in between them and the state level. But my question is, wouldn't that impact their jobs? Like, wouldn't they lose their jobs if they're not funded?
Yes.
So that's what I'm saying. I don't fully understand the logic. Like, aren't they gonna long-term kind of?
Well, if you think about it, and you guys jump in if I'm not getting this accurately, but if you think about it, the people who are supporting this will not be in office in 2 years. There'll be a whole new set of legislators. So I don't know if they're thinking about that or not. I know one of the things in the comments we hear often is that the system is broken, and that is disturbing because that says that the people here and the people in this community aren't doing well by the individuals who need our services and supports. And what I will say is that we're not perfect, and I would say that it probably is a better investment to look at how do we improve what we have as opposed to dismantling what is already working. And so the money that has to go into dismantling and rebuilding is enormous. So if we could direct our efforts in fixing those things, these are the same things I saw 5 years ago when I walked through the door, and that is we need improved access, and we also need to have a more robust crisis response system, right? I started during the pandemic, so some of those things were difficult to do because,
the situation we were in. We also needed to improve on how we integrate care, and we've done those things, and then build a system of care that truly wraps around families and children and the people in our community that we serve is really, really critical, and making sure that we address any gaps in care. And so those are the things that I would say really do align with what I've heard the state say about the improvements that are needed. Other things, and I think this is really big for Oakland County, improving our provider relations. When you have limited funds, it's really hard to support your providers in a way in which you have to manage your funding that you get. So we've made changes to improve that process, and it's been good for some and not very good for others. And we're honest about that. But it is a process that we had to go through because of the constraints on our funding. The other thing that I say, and this is big, is the workforce in our development. And initially, I really thought about the external workforce, but I also am thinking about my internal team who are working and rolling up their sleeves every single day. They love the work that we do. They're committed to the work that we do, and they're listening to you all, and they're listening to this community. So really supporting our workforce. And then the lowest paid workforce in our community is the direct care workers. We are truly trying to advocate to the state, to our local legislators about how do we support this workforce. If it had not been for direct care workers, many people in this room, family members, friends in this community would not have made it through the pandemic. We had people who stayed, did not go home to their own families, went to hotel rooms so that they could keep the individuals that they work for and serve safe, healthy, alive. So those are the kind of things that you don't get to hear. So truly in advocating, we need those stories. We need to tell the true personal stories about what's going on. We also need the data. We have to have data to support what we're doing in outcomes and things of that nature. But something that's truly impactful to what we do is having stories that inspire hope. Again, I don't want to sugarcoat anything. We're not perfect, but we have a great opportunity to make improvements to what we do. And the only way that we do that and the success that we have seen is as we're coming together to do that. The success of the programs that Commissioner Spiz talked about and what Kevin is in support of in terms of NAMI and CIT is because we come together, not because we're saying, well, who's going to put up the money for this? But we're saying, well, let's put our resources together and figure out how to support our community. So we don't get to hear the good outcomes that are happening because we're distracted by, I would call this RFP a very, very loud noise, right? And so how do we respond to that, knowing that, you know, it's tough for some of us in the room. I'm looking at Tracy and thinking it's tough when you have to go against your funder, right? So we need that support to work together because the funding is not going to me and Tracy. It's going to this community. And we push out 96% or 94% of those dollars out the door to our providers. And we know it's not enough, but taking resources away from the work that we need to be doing doesn't help. So again, I want to thank you all so much for being here and sharing your stories, asking us those tough questions, because my team will tell you, we believe in accountability, and it's mutual accountability. We are accountable to you. And I require our team to be accountable to you. And then you all have to be accountable as well in how we serve this community and what we do to advocate and maintain the public system. Because I've worked in private sector, Kevin had, you still do, right? And it is about profit. And thank you so much about the comment about profit before people. We need to make sure we're making decisions that are about the people in this room and our families and the communities that we serve. Because we can do that. We definitely can do that. But it's really hard to do in 41 days, right? So with that, I won't keep you any longer. I do want to thank you. Our door is always open. Please provide comments in the QR code. So thank you so much. Oh, we have one more comment, I think.
Before everybody leaves here, could we just try one thing? try to make a motion that we met here at your request?
Yes.
Send to the governor to say, please do not allow what is happening to our mental health.
Yes.
We have a lot of people here. You have a lot of people online. You have plenty to say. Please do so.
Yes.
I make a motion that you do that. And if nobody else.
We'll send out something asking for permission to publish your name. And if you allow us to do that, we will definitely send something to
You
the
can
governor.
publish my name and you
Yes.
can publish my
We
husband's
want to ask
name.
everybody in the room, but we're very open to doing that. So
Please.
thank you so much. That's an amazing suggestion.
Now, if you don't have guts to say yes to it, shame on you. It's nice talking.